Dr. Baliga here. Today's podcast is a part of my God Knowledge Doc podcast aimed at making you, the clinician, a better clinician. You can follow me on Twitter at RRBaliga, MD. Today's podcast is on the concept of door-to-GDMT time and door-to-maximum dose GDMT time. This presentation will contain data to make a case for the early initiation of therapy from day one of diagnosis of heart failure and the importance of titrating up to maximum dose as soon as possible, even within a month. I hope this terrific podcast will be thought-provoking and make you, the practicing clinician, better serve your patients. The podcast is derived from a book I edit called Baliga's Textbook Internal Medicine, available at mastermedfax.com. It's a terrific book with authors from elite institutions. I would like to acknowledge Dr. Muthaiya Viduganathan from the Brigham and Women's Hospital and Harvard Medical School, Dr. Greg Fonero, Chief of Cardiology at UCLA, and Dr. Bertram Pitt, Senior Physician at the University of Michigan, for sharing me the slides and thoughts which help me better develop this podcast. In addition, I've used material from the textbooks I've edited with Dr. Bertram Pitt, Dr. Mike Giverts on the management of heart failure, and Dr. Gary Haas from the Ohio State University, who served as the director of the program, from the Color Atlas and Synopsis of Heart Failure, which belongs to a series edited by Dr. Bill Abraham, who was until recently Chief of Cardiology at Ohio State. These books have been translated into Mandarin and Italian. In addition, I served as the editor of Heart Failure Clinics of North America with Dr. Jim Young from the Cleveland Clinic, and we even had some terrific contributors for the series, including Dr. Braunwald. We all now know the four pillars of therapy for HFrEF. They're ARNIs, beta blockers, mineralocorticoid receptor antagonists, and the SGLT2 inhibitors. These four horsemen are here to stay and have made a big difference in improving survival in HFrEF. If you look at the 2-year mortality in HFrEF with no therapies as high as 35%. With the addition of ARNI imputed instead of ACE inhibitors, there's a 25.2 2-year reduction in mortality and a further 16.4 absolute reduction with the addition of beta blockers, 11.5% reduction with the mineralocorticoid receptor antagonists. And once you add SGLT2 inhibitors, the relative risk decreases up to by a further 17%, and the absolute mortality reduces to less than 10%. The cumulative reduction in mortality, if all these evidence-based therapies are used, the relative risk reduction will be nearly 73%, and the absolute risk reduction will be 25%, and the number needed to treat will be about 4 patients. This slide is thanks to Dr. Greg Fonero from UCLA. So we know that there is a significant improvement in mortality with the start of these 4 horsemen for HFrEF. But today I'm going to make a case that it's important to start early and up titrate to maximum dose within a month. Heart failure has a very bad prognosis. When compared to the US population, patients across all age groups have a markedly lower median survival. In fact, people between the age of 65 and 70 have nearly 13% reduction in their life expectancy. And even in 90-year-olds, which is at the right panel, there is a 4-year reduction in mortality, at least in HFrEF. And this slide is courtesy of Dr. Kevin Shaw and Dr. Greg Fonero from UCLA. What is the early mortality in heart failure? The Framingham Heart Study reported in 2002 there's a 10% reduction at the first 30 days after diagnosis, and as high as 25% at the end of 1 year, and as high as 50% mortality over 5 years of follow-up. It's worse than cancer. And this was reported in the New England Journal in 2002. And more recently, Nicole Conrad showed there is a standstill in improvement in mortality. And this was reported in JAMA Cardiology 2019 November issue. The mortality is as high as cancer. Rishi Vadera and Robert Ye had shown that 1 in 4 patients in the US hospitalized for heart failure die or are re-hospitalized within 30 days of discharge. So the mortality is significant with heart failure. The SOLVE study showed that even in asymptomatic patients with reduced left ventricular ejection fraction, the enalapril and the placebo arms separate out as early as 3 months. Okay, but most of our mortality, as I reported earlier, is in the first month. So it takes about 3 months with ACE inhibitors. An analysis of the Ephesus trial found that the timing of eplerenone initiation and outcomes in post-MI patients with heart failure, the importance of early administration within a week, 3 to 7 days, improved outcomes, whereas the benefit was not observed when eplerenone was initiated after a week. This article was authored by Chris Adamopoulos, and the senior authors were Dr. Bertram Pitt and Dr. Faiz Zanad of the Ephesus investigators. In the Pioneer heart failure, in acute heart failure, Dr. David Morrow and collaborators showed that the composite endpoints of cardiovascular death and rehospitalization for heart failure separated out within 2 weeks of initiating therapy with ARNI and remained efficacious through the 8 weeks that was consistent with its established efficacy reported in chronic heart failure. The same investigators in the New England Journal of Medicine showed that there was a greater reduction in NT-proBNP concentration with ARNI, that is sacubitril valsartan, than compared to enalapril as early as the first week. So these drugs kick in early after initiating therapy. In the paradigm heart failure, Milton Packer and others showed that the curves between ARNI and enalapril separated out within 10 days and persisted up to 30 days in this graph reported in circulation. And when they looked at the corresponding levels of NT-proBNP and troponin, they found substantial improvements in NT-proBNP and troponin at 4 weeks after therapy with ARNI when compared to enalapril. So you can see that the ARNIs have lower NT-proBNP and have lower troponin T at 4 weeks of time. Other investigators have shown that with initiation of ARNI, plasma aldosterone, plasma endothelin, and plasma and urine NT-proBNP all improve within 7 days and are statistically significant within 3 weeks. So the efficacy of ARNI is within a month. It saves lives. It has favorable neurohormonal effects as soon as therapy is started. Now switching gears to SGLT2 inhibitors, the new kids on the block, so as to speak. When you look at the 3 trials, the TAPA heart failure, the Soloist acute heart failure trial, and the Emperor reduced, all of them showed significantly clinically relevant benefits within 28 days of initiation. That is, in DAPA heart failure, there was a 49% reduction in events by day 28. In soloist acute heart failure, there was a 39% reduction in events by day 28. In the Emperor reduced, the benefit reached statistical significance as early as 12 days after randomization. And in fact, you can see at day 12 the curves separate out, and by day 34 the curves are nicely separated out, and empagliflozin has significant benefits early after therapy is started with SGLT2 inhibitors. Interestingly, with SGLT2 inhibitors, the blood pressure response is kind of bimodal. There's a slight increase in blood pressure, in systolic blood pressure, when the baseline blood pressure is less than 110 millimeters of mercury. There was no change when the blood pressure was between 100 and 130 millimeters of mercury systolic. And there was a slight reduction in blood pressure when the baseline blood pressure was above 130 millimeters of mercury. And this is because of the tubular-glomerular feedback seen with the SGLT2 inhibitors. And you know, a lot of people are nervous about starting blood pressure reducing agents in our HFrEF patients, but the frank starting curve in HFrEF is flat compared to the normal steep curve, and there is small reduction in blood pressure even with the other blood pressure reducing GDMT. But with SGLT2 inhibitors, there's actually a slight increase in systolic blood pressure when the baseline blood pressure is soft. There was similar findings in the Copernicus trial with carvedilol in patients with pre-treatment systolic blood pressure of 85 to 95. There was no evidence of any initial decline. In fact, there was a slight increase in systolic blood pressure after carvedilol was initiated. But in all comers, there was a fall in blood pressure. So when the baseline blood pressure is higher, there's a fall with carvedilol, but when the blood pressure is soft, there is actually an increase in blood pressure with carvedilol. And again, in my opinion, just like SGLT2 inhibitors, the alpha-1 blocking properties of carvedilol has a beneficial effect on tubular-glomerular feedback. So when the baseline blood pressure is soft, the blood pressure actually goes up with these group of agents. When the baseline blood pressure is high, they actually reduce the blood pressure, and the tubular-glomerular feedback is probably the main mechanism by how this happens. Milton Packer and John McMurray have recommended to start beta blockers and SGLT2 inhibitors right off the bat, and then start ARNI, and then start mineralocorticoid receptor antagonists. They argued for beta blockers because beta blockers save lives by reducing sudden death. But I will also argue that if you start carvedilol and SGLT2 inhibitors, even when the blood pressure is soft, if anything, there will be a slight increase in blood pressure depending on the trial data. And this will allow you to initiate ARNI and mineralocorticoid receptor antagonists. Dr. Greg Fonerow proposes that low dose of all the 4 GDMTs, that is ARNI, beta blockers, mineralocorticoid receptor antagonists, and SGLT2 inhibitors, are started right off the bat on the very first day. The good news is with SGLT2 inhibitors, the maximum dose, that is 10 mg of dapagliflozin or 10 mg of empagliflozin, can be started on the first day, and there's no need for titration. For beta blockers, I like to go up on the dose when they're dry. So start low and go slow. With ARNIs and mineralocorticoid receptor antagonists, one has to be careful when they're too dry, so that they don't get isotemic. Dr. Fonerow argues the advantage of simultaneous initiation of GDMT decrease the risk of hyperkalemia, which may favor less discontinuation of mineralocorticoid receptor antagonists. In fact, starting ARNI instead of ACE inhibitors, there will be less hyperkalemia. Similarly, the use of SGLT2 inhibitors may decrease the risk of hyperkalemia. Furthermore, SGLT2 inhibitor therapy may slow the progression of kidney dysfunction, as shown in DAPA-CKD, which may enable persistence of ARNI and MRA therapy. Now I'd like to switch gears to the mode of death in heart failure. This is from the Bennett CHF study. In NYHA class 2 and NYHA class 3 heart failure, sudden death is the main reason for death in heart failure. In NYHA class 4, however, it's all pump dysfunction, and then sudden death is the second important cause for death in NYHA class 4. But in NYHA class 2 and class 3, sudden death is the reason for mortality. In the MERIT heart failure trial, beta blockers helped by improving sudden death, total cardiovascular mortality, and also death from pump failure, and even total mortality was reduced. In the EPHESIS study, eplerenone reduced sudden death by 21%. And in the paradigm heart failure, there was a 20% reduction in sudden death and a 21% reduction in heart failure death or due to pump dysfunction. So there was 20% reduction in sudden death with ARNI and 21% reduction in pump failure death. And in the with DAPA, the SGLT2 inhibitors, again there was a separation of the curves at 270 days with dapagliflozin, and the SGLT2 inhibitors also decrease ventricular arrhythmias, resuscitated cardiac arrest, or sudden death in the DAPA heart failure study. I want to thank Dr. Muthaiah Vaduganathan for giving me this slide. So when you look at all-cause mortality, more and more people are dying, but remember, our medications are improving both sudden death, that is reducing the burden of sudden death, and death due to pump function. In fact, more and more in our practice, we are seeing with the utilization of GDMT, patients are presenting with ventricular arrhythmias rather than pump failure. And very often we have to do cervical sympathectomy to reduce it. The mortality remains high despite the 4 pillars of GDMT. It's as high as 10%. So something to keep in mind. There's a lot of room for improvement in improving survival in our patients with heart failure. In fact, I would argue that the best way we could get since we can start therapy early in hospital, but it is important to get to maximum dose within a month, since most mortality occurs within a month. I would recommend a pharmacist-driven GDMT clinic. The main barrier for early adoption of all 4 therapies is cost, but it's very important to take home the point that to start GDMT right off the bat, particularly I would argue beta blockers and SGLT2 inhibitors, and even roll in a low dose of ARNI if the blood pressure is not soft. And Dr. Vaduganathan and others have shown that when compared to ACE inhibitors and beta blockers, switching to ARNI, starting an MRA and starting SGLT2 inhibitors extends a patient's life by 6.3 years. So overall, these 4 drugs are great in increasing life, but we need to also capture the mortality in the first month. And I would argue that starting these medications right off the bat, we may save more lives. Dr. Greg Fonarow argues that simultaneous or rapid sequence initiation of these four pillars of GDMT, there will be rapid reduction in heart failure hospitalizations, rapid reduction in rehospitalization for heart failure, rapid reduction in mortality, improved use of adherence, persistence, and overcoming inertia of up-titrating therapies, improved health status, and improvement in LV ejection fraction. So, I would argue, given that ARNIs, SGLT2 inhibitors, and eplerenone all have shown to be efficacious within days to weeks, time is life. So I would argue that we need a metric, a door to GDMT time, and another metric, door to maximum dose GDMT time. Delaying therapy may be fatal, and therefore early therapy is vital. Don't wait for guideline committees and consensus decisions. Go for it. Start therapy as soon as possible, despite barriers. There's a very elegant editorial by Dr. Javid Butler, Dr. Greg Fonero, and Dr. Stephen Green on this simultaneous or rapid sequence initiation of these four pillars for heart failure on March 31st of this year in JAMA Cardiology. And this is particularly important in those patients with an elevated BNP. If you agree with me, follow me on Twitter and answer my poll. Yes, you agree early initiation is important for GDMT. No, it's not. Maybe. Or the fourth option is maybe insurance companies. I look forward to hearing your responses on Twitter.